Good morning, everyone. And on behalf of the HSE National Research and Development Team, I want to once again extend a very warm welcome to you all to the fifth of our 2022 series of Share and Learn seminars. As those of you who've attended before will know, through the seminars we're supporting researchers to share their research findings and their research knowledge across HSE and with our partner organisations, and particularly to share examples of how to get research into practice and policy. So I'm Virginia Minogue, one of the workstream leads for knowledge translation impact, and I have some of my colleagues from the team also on the call this morning. If anyone experiences any technical difficulties during the session, you can join the seminar by phone, and the details of how to do so should be in the chat function. Before I start, I want to remind everybody of the resources that we've mentioned in previous seminars that are available to support you in using your research knowledge, including guidance and training modules. And we've put a link, or we will be putting a link to the R&D website and the resources into the chat function for anyone who'd like to use them. And please, of course, get in contact with us if you want support. So, as with our previous seminars, we're very lucky to have two great speakers with us today, both of whom are leaders on two of our HSE national programmes. We've got Maria O'Brien, Programme Manager for the National Heart Programme, and Anita Manelli from the National Office for Suicide Prevention. So each of our speakers will be given a presentation, and after each one, we'll have an opportunity to ask any questions. You are muted during the call, so please submit your questions into the chat function. And when you add a question to the chat, please make sure that you send your questions to the panelists. I also want to let you know that we're recording the presentations and that they will be available after the event. So our first speaker is Maria O'Brien, and Maria is going to be talking about making every contact count, the implementation strategies, and using knowledge translation as part of research. So the presentation is going to show us how the research has used knowledge translation and present some of the findings of this research to date. Maria, you're very welcome, and we're really looking forward to hearing about the programme and the research part of it.
Thanks very much, Virginia, and I'm delighted to be here this morning just to give people, I suppose, a flavour of some of the findings which are coming from the research piece of work that we've been engaged with, and also, I suppose, to talk a little bit about how we actually used knowledge translation in terms of that, as part of that research, and in terms of generating some of the research outcomes. So, I suppose, just by way of background to this piece of work, the Making MEC work study is, I suppose, a partnership between the HSE and the Health Behaviour Change Research Group in NUI Galway. And I suppose we have had a history of partnership between Professor Molly Byrne and the HSE and the MEC programme through a number of the development of the MEC programme since about 2015. So when we were looking at the development of the framework, development of the undergraduate curriculum, and also when we were looking at developing the training programme, that the programme itself would have had a lot of interaction, and we would have had, I suppose, engagement with them as an academic consult in terms of the work that we were doing. Another piece, I suppose, and I suppose how the Making MEC work study actually came about was NUI Galway, I suppose, ran a Health Research Board knowledge exchange and dissemination workshop, probably back in about 2019, and it was looking to identify HSE research priorities and strategies. And one of the, I suppose, I attended that workshop from the MEC programme, and as did a number of my colleagues from Health and Wellbeing at the time. And one of the, I suppose, priorities identified was optimising the implementation of Making Every Contact Count. So with that in mind, we, I suppose, applied for a HRB partnership award to fund the research, and it was a joint application between the HSE and NUI Galway to look at optimising the implementation of MEC development strategy. So we looked for a 24-month project and were granted funding for just under €240,000. And that, I suppose, is the research study and the piece of work that has generated the research findings that I'm going to present to you today. Just looking here in terms of the team and who was the team for that Making MEC Work Applied Partnership Award, I was and still am the knowledge user for the principal investigator from the knowledge user, which is the HSE principal investigator. The academic principal investigator was Professor Molly Byrne, and we have a postdoctoral researcher working with us at the moment, and Dragomir, who's just replaced Una Mead, who's taken up a new role. We had a number of co-applicants, a number of collaborators, and we also had a PPI panel, which was very important. So we had our study management team, which was made up of myself, Molly, Una, and Jenny McSherry. And then feeding into that, we had the PPI panel. We had a study steering committee, which was made up of the collaborators and the co-applicants. And then also a key, I suppose, stakeholder to engage with a MEC implementation group, because they were essentially, I suppose, the group that were looking at commissioning this research to support the implementation of the MEC program going forward. I suppose one of the other key things that really has made this a priority since we started the research back in 2019 was the publishing of the integrated care program for the prevention and management of chronic disease, the model of care for that program. And as you can see, the model is here in a pyramid, but one of the foundation stones of it is making every contact count. And the idea there being that, I suppose, making every contact count is implemented across all programs for the prevention and management of chronic disease, which further embedded the program and, I suppose, further created the need and the push for to have a scaled up implementation of the next program. So just an overview of the project and what it looks like and what we aimed to do in terms of the research. And again, you can see up here. So I suppose the Making MEC Work program was broken down into 3 work packages. The first one was mapping barriers and enablers to MEC delivery. So there was two studies to this piece, and I'll present some of the findings on these. So there was a healthcare professional survey. So we surveyed anybody who had actually completed the Making Every Contact Count training program, e-learning program, to see to try and identify the barriers and enablers for MEC delivery. And then the other piece of that was a qualitative study where we interviewed 36 healthcare professionals, again, to look at the mapping the barriers and enablers to the work. Second work package, which is just currently being completed, is understanding patient attitudes and experiences. I don't have findings on that to present today, but hopefully we'll be able to present those at a later date. The third work package was development of a collaborative implementation strategy. And I thought this is where using knowledge translation as part of the research came in, and I will present some of the findings of those to you as well today. So just in terms of the first survey results there, what did we kind of find? So we had 357 participants, and I suppose it's really important to point out that we got the funding for this program kind of early 2020, and then COVID hit, which really had a significant impact on our ability to do the research in the time frame that we were planning to do it in. So we have had to request and were granted a no-cost extension just in terms of the timelines, because of 2020 just wasn't an environment, and a lot of 2021 either, where we could actually engage with healthcare professionals, because as we know, we and all of them were busy dealing with COVID and the crisis that it was. So I suppose it's really good to actually get to this point with the research, and once things quieten down in terms of COVID, we have some really good engagement across the system from healthcare professionals. So the age range was from 22 to 68 years, and 89% females and 11% males. What made up, I suppose, the study cohort. And the most relevant professions, significant numbers of nurses, physiotherapists, and midwives, which would be, I suppose, indicative of the numbers that we would see coming through the training program as well. 76% of staff were full-time, 93% working in the HSE, and 30% had also attended the additional enhancing the skills workshop, which is the face-to-face workshop that follows the e-learning program. So what were identified as some of the survey barriers and enablers, these are some of the survey findings that we found. So knowledge, skills, were identified as key items there. Professional role, I suppose, understanding that MEC was part of the professional role and having, I suppose, not even a directive, but a mandate that it was part of the role was really important. Beliefs about people's capabilities and their ability to deliver brief interventions effectively. Optimistic beliefs about the consequences. So that was believing that it was worth doing and that it would actually have benefit to the patient. People's intentions and goals. So that was, I suppose, around the intentions and goals of the patient and maybe where their commitment to that was. Barriers to prioritisation were, I suppose, identified as by staff, and I suppose the piece there was looking at within their workload the barriers that they had to try and prioritise, in integrating MEC as part of their daily work. The other piece is what that was positive there was that fit with clinical practice. Environmental resources were identified as an enabler and a barrier, so the lack of them was a barrier, but having them there was an enabler. And social influence was again, so I suppose it was, the collective effort and the social influence that I suppose existed within the workplace to collectively integrate MEC as part of the way the service operated. So they were some of the barriers and enablers that were identified from the survey results. And this I suppose was kind of a step-by-step process because we wanted to get to a point where we could actually identify strategies and that we could, I suppose, come to some consensus on as the key priority strategies for trying to upscale the implementation of the program. Just again, some findings here, barriers and enablers from the qualitative interview results, and I won't go through them all, but as you can see, we grouped them again under similar domains, and we will use the theoretical domains framework in terms of grouping for those of you maybe who might be familiar with it. But just even some of the, you can see again some of the themes that were coming up, and some of the commentaries or more detailed pieces were there, are here and explained. So I suppose these were the basis then that the findings from this survey and also from the previous study 1.1 were, I suppose, what we used then as part of the process to try and reach consensus with key stakeholders to see if we could come to consensus as to what would be the priority for implementing MEC going forward. So what I want to talk to you a little bit about now is, I suppose, the process that we used to do this consensus process, but also, I suppose, to demonstrate the use of knowledge translation and disseminating findings from the earlier research to help inform the consensus process and the formation of implementation strategies. So this consensus process was studies 3.1 and 3.2, and it was kind of carried out in a two-step way. So first of all, we did an online stakeholder consultation survey. So we identified as both key stakeholders that were to be engaged and invited to the consensus process. And each of them was invited to complete the consultation survey online. And this was used to collect recommendations to enhance and make the other contact count implementation under the theoretical domain framework domain, as you saw there in the previous table. 43 unique recommendations were developed from this process. We categorized them using the COM-BEAM model. So under capability, we had 10, opportunity, there was 18, and under motivation, there was 15. And it was those, I suppose, 43 unique recommendations which we then used as part of the stakeholder consensus workshop to discuss, rate, and to, I suppose, identify which would go forward as a key priority strategies for implementing MEC. So in total on the day, due to a number of different issues and sickness, we had a reduced number of 17 on the day with stakeholders. Unfortunately, a couple of our participants fell to COVID, but luckily they recovered and were fine. But unfortunately they weren't able to attend on the day but had submitted through the survey piece. So how we, I suppose, the next two slides are just going to outline, I suppose, how we actually used the knowledge and the research that we gathered from the earlier studies in a kind of a knowledge translation process to then lead to the consensus process at the end of the 2 days. So we started off with a kind of a staggered 2 days, half day starting on after lunch on the first day, gave an update and an overview of the program. We had patient practitioner perspectives as well, which was really important. And we had our international experts there who were also collaborating on the research project. So it was really good to get some international perspective and international update and dissemination of research findings from Chris Keyword there and his team in Leeds, who's been involved in MEC evaluation in the UK. But I suppose that was kind of where knowledge translation first kind of impacted on our consensus process. And then the next piece there was where Dr. Ulamid, who was the doctoral researcher who's been working on the program for 2 years, but as I mentioned, has now moved on to a new role, presented the findings of the research as they happened up to that point. So then we broke down into groups and, you know, it was reviewed and discussed and reviewed and discussed. And we came back the next day and looked again at, I suppose, reviewing and refining the strategies which had been informed by the research findings that we presented and the findings from the consensus survey which had been carried out online. And I suppose that was very useful because it was an intense process where we had to go back and forth with the group to prioritise the top 9 strategies. But we did reach consensus on what those 9 strategies were, and I present some of those to you shortly just to give you a flavour of what that looks like. And then most importantly, what we needed to talk about as well was embedding the strategies and also looking at further, I suppose, the opportunities to continue to disseminate the research findings and the consensus outcomes once they were finalised and written up. So where we're at currently is that we have written up a policy briefing document, which is now going to be presented to HSE senior management, MEC implementation group and other key stakeholder groups, and that has the key, so the top 9 strategies for priority strategies for trying to support the upscaling and implementation of MEC. And that's going to be a key activity between now and the end of the year, which is project ends in early 2023. And then obviously at that point, our job in terms of the research project will be finished, and it will be to hand the research findings, the research report, the policy briefing to the MEC implementation group for them to, I suppose, look at that and see within health and wellbeing how they're going to implement those strategies and apply those strategies and work across the system to upscale and implement the program, which was what was the purpose of the research in the first place. So that's kind of where we're at with it and where the research findings are. I actually don't have the findings from the top 9 strategies because they're just waiting for sign off. So we do. I have had to hold those just right now because we just need to get final sign off from the review group on that. But at any time in the future, I'd be very happy to present some of those findings. Or I'm sure maybe somebody from the MEC implementation group would be interested in coming and presenting those, or maybe Agatha Lawless, who's the current project manager, would be interested in maybe doing that. So we could maybe talk about that in the future. So I suppose the key thing I suppose I just wanted to highlight to people today was that, you know, the research itself was very useful and was very valuable, but the use of knowledge translation as part of that process was extremely valuable because it helped us to, first of all, disseminate the research findings that we gathered to a certain point in the program, but it also further, I suppose, helped us to reach a consensus and to, I suppose, engage key stakeholders in the actual research process itself, which again, you know, I suppose took a co-design type of approach, which again was very important from a change management perspective. So I just finished there with a picture of one of our online meetings from the actual steering group of the study management group, which would have met every 2 or 3 months to progress the piece of work and to keep the research on track. So that's it from me. Happy to take any questions.
Thank you, Maria. That was a great overview of the project, and I'm sure we look forward to hearing more about it in the future. 1 or 2 questions we've got coming through already. You mentioned knowledge translation and the knowledge translation element of the project, and your knowledge translation team was quite sizable. Were there some strategies that you used to keep everyone informed and involved in relation to the knowledge translation element of it?
Okay, so I suppose um, we had a number of strategies. I suppose we had identified our key stakeholders at an early point in the research program. So they would have been, I suppose, our key audience that we would have engaged with on a very regular basis. So we would really have just, I suppose that was the most important one, really, Virginia. It was just looking at, who were the audience and engaging very specifically with people on a very regular basis and keeping them updated where the research was, reminding them, sometimes, particularly I think what was really important was, because we experienced such delays with COVID and everything, it was really important in terms of keeping that on people's agendas and keeping the research going from that perspective.
Yeah, thanks very much. And another question from Mary Morrissey. What insights or learning about knowledge translation could you offer to others? What would you do differently, and what would you definitely do again?
Okay. I suppose the one thing that I learned about the knowledge translation, and I suppose it's a bit the nerd in me when, I love the research piece and the detail and the statistic piece and the frameworks and knowing what's being used to do what. The reality is, for a lot, there's only a certain audience will want to know a certain level of detail of the actual methodology, that they'll want to know the details of the statistics, the power, the weight that's coming behind everything. And I think for me, the learning around it was that a lot of people maybe don't understand that. So, like say I presented the table there today with all the odds ratios and all of that. A lot of people don't understand that if they haven't come from a research background. So for me, I think the learning was about trying to translate some the statistical piece or the actual research findings into something that's practical and understandable for people and for the audience maybe that you're presenting to that don't maybe have a research background as such. So that was one thing. The piece that I would definitely hold on to for future study was, I think, the whole use of the knowledge translation piece to forming consensus. I think that was actually really important. Because otherwise what we could have done is bring all the key stakeholders into the room and maybe just say, look, well, these are some of the findings. And we could have ended up with a very unwieldy conversation that would have produced strategies, but with that strategies that would not necessarily have been based on evidence. And I think that's a real strength of what we've produced in terms of the implementation strategies, that they are evidence-based strategies. And that, I think, has huge weight, and that's definitely something that I would hold on to.
Thanks very much. And I think what comes through clearly is different messages for different audiences in many respects. Yeah. Another question, are there plans for follow-up, more long-term follow-up to assess the impact of the programme?
I suppose I'm not involved in the programme anymore because I've moved on to another role, but I suppose I'm still kind of involved in the research piece, so that's why I'm here today talking to you about that. I think that's probably a question for the next implementation programme. I mean, really, at this point, where the programme is at, and obviously implementation of the programme has been impacted significantly because of COVID as well. It's timely that we've been coming back into a settled period of service delivery, and people have been returning to their roles where they were all redeployed from, and MEC has been really and very much coming back to the fore in the last 6 months. We now have these implementation strategies to help, I suppose, bring it forward even more. So we need to implement those strategies and see how they're going to work. And definitely there should be a longer term follow-up to assess the impact of the programme and certainly the impact of the strategies that have been put forward. But at this point in time, there isn't something there to look at that. But I think it is under discussion.
Thank you. Can I just ask a question? You mentioned, I think on one of your very early slides, that you'd had a patient and public involvement advisory group working with you. And I wonder if you could tell us a bit more about their role in the project and the design of the project.
So they have a PPI group through NUIG, and we tapped into that, I suppose, as a source to support the work that we were doing. We actually had patient representatives on our study management group and on our steering group, which was really important there. And there would have been ongoing, I suppose, dissemination and engagement processes by Una Mead, the postdoctoral researcher, with the PPI group at all stages of the research. So when we were, designing the research process, we had engaged with them, but also, I suppose, when we were looking at the ethical approval and looking at actually, implementing the studies and doing the piece of work, we would have engaged and kept them involved in that process right the way through and taken their views on board. And most importantly, for the work package, which is just concluding at the moment, which is the patient perspective, there's been a very significant patient and PPI involvement there in the design of that study and in the execution of it. So we'll be looking forward to those results coming in the early new year.
That's great. Thanks very much. Well, thanks very much, Maria, for giving us such a good oversight of the different work packages in the project. And I'm sure we'll be delighted to hear about progress as we go along of those different work packages. Obviously, a really important project, national project for us. So thanks very much for that. You're very welcome. Thank you. Thanks very much. So our next speaker this morning is Anita Manelli. And Anita's going to be talking about using research informed service delivery for Connecting for Life, Ireland's national strategy to reduce deaths by suicide. And the presentation is going to look at how Connecting for Life uses research to impact on policy and services. Anita, you're very welcome.
Thanks, Virginia, for the introduction and for asking me here today to present on the work of some of our work. I had said I'd look at two different projects, but just for time constraints, I'll only focus on one that we conducted internally in our office, and it's maybe on a smaller scale to what Maria presented, but hopefully it will be of interest to everyone here today. I'm going to start with just giving a bit of a background to Connecting for Life and its strategic journey. So we have, in 2005, we had Ireland's first national strategy for suicide prevention. So this was called Reach Out, and around until 2014. At the same time, then a few years later, then we had the Healthy Ireland strategy. And then we in 2015 launched our second national strategy for suicide prevention, Connecting for Life. This involves an implementation plan where actions are in the strategy and they are assigned different lead agents who have responsibility for implementing those actions in an attempt to reduce suicide in Ireland. At the same time, then we have 17 local Connecting for Life action plans. So these are run by resource officers for suicide prevention who have their own steering and implementation working groups and they are responsible for these actions in their own areas. In 2019, then we had an interim strategy review, which was conducted by an independent board of assessors. So they rated progress to date on our actions in Connecting for Life, and they made important recommendations for priorities for the next number of years. But also that this interim strategy review as well was very important because it helped secure additional funding for our strategy so that it was extended then until 2024. So we're currently working off an implementation plan for 2020 to 2022, and we'll be developing our next one for the final 2 years of the current strategy. At the same time as the first strategy was launched, our office, the National Office for Suicide Prevention, was established. We have a number of different work streams in our office. So I'm on the research monitoring and evaluation team. We have a communications function with strategy, quality, coordination, and education and training. We also have then a clinical advisor to our office as well. Our work then as well also feeds into other strategies, and other strategies then will feed into some of our work. So our colleagues in HSE Mental Health will have responsibility for a number of actions in our strategy, and will have responsibility for actions in mental health policy. So for example, a vision for change in 2006, and also it's more recently updated to sharing the vision. So we will have responsibility for a number of actions in that strategy as well. Then just to look then at Connecting for Life globally, Ireland is one of 38 countries to have a national standalone suicide prevention strategy, which has been adopted by government. and we were one of an even fewer number then that actually are on our second national strategy. So we are included then as an example in the WHO guidelines on for countries looking to develop their own national suicide prevention strategies. So Ireland, some of the examples of work we have done are included in this guidance. In terms of then oversight over our strategy, it is overseen by a cross-sectoral steering group committee. So this consists of a number of government departments and is chaired by the Department of Health. There's also representation on this group from the non-governmental organisations, and we also have representation from the HSE. So some of the agents on this group are the Department of Education, Department of Agriculture, Food and the Marine, and the Department of Justice. So this group would meet quarterly, and individuals, organisations with responsibility for actions would report in on their progress in our quarterly monitoring report, and then we present back the information at these cross-sectoral meetings and flag any areas that are in need of attention, and so that the group can work together to come up with any possible solutions. So in terms of the 7 different goals then in Connecting for Life, there are 69 actions as part of these goals. The first goal looks at improved understanding. The second goal looks at empowered communities. The third goal looks at priority groups. The fourth goal looks at better access to support. Goal 5 looks at high quality services. Goal 6 looks at reduced access to means. And goal 7 then looks at better data and research. So goal 7 there is where my work would mainly fall under in the office. Looking at our strategic context then for goal 7, we're looking to improve surveillance, evaluation and high quality research relating to suicidal behaviour. So under this goal then we have 4 different actions. In terms of the overall strategy, the 2 main outcomes are to reduce the rates of suicide in Ireland and also to reduce the rates of self-harm in the population. However, it can be, in terms of reducing the rates of suicide, it will be difficult for us to know at the end of the strategy if the rates have reduced, as there is a 2-year delay from when we get the official suicide statistics. So we often work off, we're working off intermediate outcomes on actions to see if we can, to show how we're making our progress at the moment. So in terms of action 7.1, it's looking at evaluating the effectiveness and cost effectiveness of Connecting for Life. 7.2 looks to improve access to timely and high quality data on suicide and self-harm. 7.3 looks to review current recording procedures for death by suicide. And 7.4 looks to develop a national research and evaluation plan that supports innovation aimed at early identification of suicide risk, assessment, intervention and prevention. So that's just an overview then of our strategy and our goals and actions in the strategy. I suppose I'm kind of looking more at an evaluation of the delivery of online suicide prevention programme in my presentation today. This is called Living Work Start programme. In our office, we have deliver self-harm, suicide awareness, suicide prevention training and bereavement training to over 10,000 individuals in Ireland annually. These trainings are provided free of charge to people in the community, but also there are certain trainings then that are targeted at individuals at risk of suicide and self-harm. I suppose as Maria said earlier, the COVID-19 pandemic had disrupted the delivery of services, and again, this also impacted our office in terms of the delivery of suicide prevention training programs, because all these programs have been delivered face-to-face. So our office then started to look at what we could do in the absence of these trainings, the face-to-face trainings, and looked at online options to see if it was possible to move these online. But however, we did at the same time this pandemic just hit, Living Work Start, so that's the name of the organisation, Living Works, and their programme is called Start, had just launched their new online suicide prevention training programme. So our office decided to initially invest in 1,000 licenses, and then we were given another 1,000 at a discounted rate. So it was important then for us to kind of look at how we could, we needed to look to see if the programme was going to deliver on its intended learner outcomes. The initial investment was there just so that we could see this set up and evaluation, just to see, if we would be able to invest in this in the future, and also, for the delivery of online suicide prevention training, would it work and would people be happy attending such a training? In terms of the programme itself, the Living Work Start programme is a 90-minute online interactive training programme that gives learners the skills and knowledge to keep others safe from suicide. So it is suitable to anyone over the age of 18 who wants to help prevent suicide and is prepared to become more suicide alert. So it has been described by individuals as a powerful interactive experience. So when a participant logs on and takes part in the training, they learn the task model. So the 4 steps of this are to tune into the possibility of suicide, to learn to ask about suicide, to state that suicide is serious, to connect to help. So this means here, when you're on the training program, you can access different resources that are relevant to your country. So the HSE NOSP have tailored supports here for Ireland. So if you click on, you'll be brought to support services such as Text 5808, yourmentalhealth.ie, and the Samaritans, and all the relevant numbers to Ireland. And then, from this knowledge information you receive, we would hope that you'd have increased knowledge of the resources available to keep someone safe at the end of training. When you look to book onto the Living Works START programme, you're given information about the National Office for Suicide Prevention, what the Living Works START programme is, who the training is for, what you will learn from the training, how is it different to other workshops that we may offer, and how does the programme work. And we also give you some information then on the organisation Living Works, who are running the programme. So the programme that we got is from the organisation in Canada. Then just to have a look at what the program looks like when you log on, you're able to use it on any computer device or tablet. Just as I've gone through, it trains individuals to recognise when others are struggling and connect them to help. When you have a license to log in, you're able to go back to the program as many times as possible and go through all the scenarios and practice and have access to the resources. And you can download the information for support services around Ireland and have that at your hand if you are ever in need of it when you're dealing with someone who may be in distress. And one of the nice features of this program is that there's interactive learning and simulations. So it's kind of, you can have a text-based conversation with someone, they will tell you how they're feeling and you can respond to them based on what you have learned as part of the training. We also then have, when you click onto the programs, there's different images here, and you can click on to see the story behind each picture and why a person may be going through a certain period of distress or suicidal ideation. And then throughout all times of the program, there's a find safety button, so you're able to click on this. It can connect you to the resource services, and also if something in the program might upset you, you're able to just log on here and take a breather and be connected in with support services as well. So it's a good safety function built into the program. In terms of what our office wanted, then again, I suppose we needed the information from an evaluation to see about the investment in the program. It's an expense, it's a big enough investment. So we looked to see, to do this. Then we looked at setting up different connections with different people to see how we could go about doing this evaluation. We first worked with the research team at Living Works to determine the most appropriate questionnaires to assess changes in knowledge, understanding, and confidence from pre to post training. So the research team there were involved with the development of the program, so they understood the content very well and were able to guide us then on what questionnaires to employ. We worked then with the IT team and the Living Works to embed the evaluation into the training program. So when participants, before they logged on to do the training, they would complete the pre-training questionnaire, and then afterwards they would complete the questionnaire. We have to complete the same questionnaire again just to assess changes in learning as a result of the training. And then we also worked with our training and education officers and our resource officers for suicide prevention to circulate information about this training program and to increase awareness about it, as it was a new offering during the pandemic. So we have a results-based monitoring and evaluation system in place as part of our national education and training plan. So here we use standardized questionnaires then from the literature to look at the changes from pre to post training. We used the Attitudes Towards Suicide Prevention questionnaire. We used 2 items for the Morris Confidence Scale. So this was used to assess confidence in dealing with individuals displaying suicide behavior, and this had been adapted from an earlier version of the confidence scale. And we also used the stigma of suicide scale. So this is used to assess stigma of suicide, and it was developed in Australia, and it has previously been used to assess stigma in the farming community and into the university undergraduate student populations. So we ran all of these questionnaires by the research team in Living Works, and they agreed that these were appropriate to look at what we were looking to see, the changes and the intended learner outcomes from the programme. In terms of the find then, sorry, this is probably a bit small now on the screen, but I think like what Marie was saying earlier, we're trying to present this information back, cut it down as much as we could possible and visually, so that we could get the information to our senior management team in the office so that they could see how effective the program was, and then to be able to make the decision on whether to invest further in the program. So what we found was that we had 161 participants who completed both the pre and post training questionnaire. So we had a lot more participants who had gone through the training, but we lost a number of them at the end who didn't complete the questionnaire at the end. We had 76% of our participants who were female, and the average age was 39 years old. It was good for us to see then that we had 83% of participants completing the training who were in a professional capacity. So that was good to see that we could get the training to these people during the pandemic in the absence of face-to-face training. And it's important that we're able to still target and get new and train up existing gatekeepers in the community. When we looked then at changes in attitudes, we found a significant improvement in participants' attitudes towards suicide prevention from pre to post training. So here, a higher score will indicate a more negative attitude, and this reduced then after training. In terms of confidence, then we had a 47% increase after training in self-reported confidence in identifying appropriate services that individuals in distress could be referred onto. And we had a 61% increase in self-reported confidence in dealing with the needs of someone who may be suicidal. When we looked at the stigma of suicide scale then, it was broken down into 3 subscales: stigma, isolation and glorification. We didn't have any significant changes on these scales from pre to post training. But we did, when we looked at the proportion of suicides that participants considered preventable, we had significantly more participants reporting that all or a large proportion of suicides are preventable. And then just in terms of the participants who took part in the training, as I mentioned, professional background was a high percentage taking part in the training. So these involve people working in social care, psychotherapists, counsellors, healthcare workers, and those in management positions. Then just to show that the back of our data dashboard, then we just give a bit of a background then to the training program, what Living Work Start is, the context in which it is there under our education and training plan, and how we have a results-based monitoring system implemented as part of our strategy. We also gathered then just a bit of qualitative feedback just from participants, just to ask them what they thought about the course themselves. We had good findings from the quantitative data, so we wanted to just supplement this with some additional feedback. So one participant reported that I found this training to be really beneficial. I would have been nervous to ask directly about suicide, but now I see it's important to ask about it clearly and directly. So it's just, I suppose, important to highlight here as well that, research has shown that it's okay to ask about suicide, and that it doesn't lead to an increase in suicidal ideation or for a person to engage in suicidal behavior. So it's really good that people from the training can see that you can ask these questions. Another participant said, I thought it was very beneficial to me, both personally and professionally. I really enjoyed the content of the training as well as the video segments. I found them to be very realistic and give a very good depiction of the reality of someone with suicidal ideation. So that was a nice feature of the program, where you could play out different scenarios, male, females, and just to see what was going on for them, and they would be acting with another person, and you could give a response then of what you thought was the most appropriate response based on what you'd learned in the training. And then finally, a comment was, I thought the training was very informative, presented to a high quality and well explained. So then just in terms of what we did, try to get this, we got this information to our senior management team in the office, presented them with the data dashboard, the qualitative findings. This led to the office, they were very impressed with the findings, so they led to an investment then of 10,000 licenses in Living Work Start, the suicide prevention training program for 2021 and 2022. So I think the evaluation was very important, that they had this information and then they could use it then to make this investment in the service. And we are continuing it on today, even with the return to the face-to-face trainings, because it is a very good option for individuals who aren't able to take a half day or 2 days off to attend an in-person training, and it does deliver on its intended learning outcomes. So we're happy to say that it's one of our suicide awareness training programs that is offered, and we have a number of different other trainings that are available on us.ie. As a result of it as well, we also are developing our own online suicide prevention training program for Irish users. I think some of the feedback additional feedback that we may have received that was that users might like some scenarios that are more relevant to the Irish community. So having had the experience with this current program, the education and training manager is working then on looking what we can do then for our own online suicide prevention training program. And just then in terms of where START sits in our terms of offerings, it's our only suicide online prevention training program at the moment. We have STORM training, suicide bereavement and understanding self-harm. So they are geared mainly at people who are working in the health and social care professions that are working with individuals at risk of suicide and self-harm. And we also then, for assistance safe talk, the health and social care workers are also can take part in this training, but these two are mainly aimed at, as well as START, for individuals in the community as well. So Assist is a 2 days intervention skills training, whereas Safe Talk is a half-day awareness training program. So that's just an overview then of where START and the evaluation and how we use the knowledge from our evaluation to inform the service delivery and how it will impact, the future work of our office then in education and training and suicide prevention trainings. Just really briefly, I'll go through this one slide on the extra project that I said I would talk about, but I didn't have time to look at this. But I've included a link here if anyone wants to go on and read the publication. Our office then in 2020 commissioned S3 Solutions to conduct a rapid assessment looking at a suicide cluster in Ballyfermot area. The researchers went into the community and did interviews there with people affected by what had happened and just looked at the different factors in the community that may have been influencing the cluster and the contagion. They made a number of important recommendations from this research, and just two here at the bottom, have been implemented. One is a new position of a community response coordinator who is working with the people in the local area on issues that are affecting them, joining up community and health services. And another recommendation, then recommendation 3, is the development of a critical incident protocol. Our office has developed a community response plan. Then it's a national guidance that communities can use in the response to suicidal incidents in the community. And we also then, there's a plan for our resource officers in each CHO area to develop their own guidance then that can be adapted to their own area. So I won't go into that, but it's available there on our website if you would like to do any further reading on it. And thanks a million for listening. We've got our evaluations research on our Connective Life website and also on nos.ie.
Thanks very much, Anita, for that excellent overview of the programme and the crucial work that's taking place within it. It's also an excellent example of bridging that gap between research and policy as well. So we've got, Mary Morrissey has said, such an innovative and important programme. From the evaluation of the programme, what changes in the programme or other development of resources would you like to see going forward?
So is that in terms of START, the programme, or in terms of the office as well and its offerings?
I guess both.
Yeah, I think it's almost like what Maria said as well. I think this is showing a really good example of how we could use our evaluation findings to influence decision making in the office. We have similar grants to Maria and the HRB Apply partnerships where we're the knowledge users. So I think it's very important going forward that we make sure that we are getting these research findings and trying to bring it into our work. And again, the stakeholder, I think, buy-in and engagement from senior managers is very important from the outset. So I think that's what I'd be working on and the team in future going forward, and trying to make sure that we had the right people buying in from the beginning and understanding and making it easy to understand our findings as well, and showing how they can influence policy and practice.
You mentioned knowledge users a couple of times, and I wonder what involvement did you have from knowledge users in the work that you were doing?
We linked up with our resource officers and our education and training officers as well. They would be the individuals who would be mainly out there promoting our training programs and involved in it. So we had like a share in our kind of our own internal session where we presented findings from the research to them. Anyone's able to take our presentation then on the findings and use it in their own areas locally as well. So I think it's very important for us to get, because we're national, to work with our colleagues then at a local level as well to get the information out there, and then also to other departments, government departments that we do work with as well, to offer it to them.
Did you have any involvement from community groups? I know you talked about engaging with people in the community, in different groups.
Yeah, we do, like our GAA are very interested in taking part in our trainings, and some of the NGO sector, they will promote our trainings a lot as well, and they would take part in it. I think maybe going forward for our development of our own program as well, there'd be more from the beginning. There would be different organizations and stakeholders involved, and as part of the knowledge translation piece as well. So I think this one maybe was quite reactive to the pandemic and to get something in place very quickly. So I think our learning is, more people on board from the beginning would be great going forward.
So it sounds like you're really thinking about a knowledge translation plan for the future.
Yes, definitely. I think it's trying to get, I've seen even our communications officers have been starting to use the different resources that the HSE have on, and how we're getting the information out there. And a lot of our work is now making our different stakeholder lists and the influence, and to make sure we get them involved at the right time as well. So
Yep, that's great. Thanks very much. I mean, one of the things that I'm very interested in, I think, is a question that we often get, and you clearly have a lot of policymakers involved in this program, and it's driven, to very, very high level. And one of the questions we often get asked is how you build those relationships with policymakers, and how you maintain those relationships with policymakers. I don't know if you've got any advice for people.
yeah, I think everyone in our office will say that our cross-sectoral steering group works really well. It's a meeting where the lead agents come together every quarter, and we have a number of different. We report back on their progress that they've made on their actions. It's a good way to showcase the good work and to build new relationships and connections there. And we can, often subgroups are then set up on actions to, that may be new to focus from members on that group. And our lead for strategy, quality and coordination and education then develops good working relations with them to kind of plan out what they would like to work on for the next year coming up as well. So I think that's a really good example of how we can work collaboratively and get the people in policy, for example, in education on board, and also other colleagues in HSE and health. So I think it's a really good way for us to do it for our strategy.
Maria, I don't know if you have any thoughts on engaging with policymakers.
Yeah, I think similar to I think it's a similar comment to Anita, in that I think really they need to be involved kind of on an ongoing basis. But I suppose from our perspective, it would be, I think a formal process of engaging with them is really important, because it's important to be able to keep them hooked in some way. It can be very difficult to build those relationships unless there is some overall group or whatever you want to call it, some forum where they're asked to, I suppose, where they're asked to, engage, or that they have an opportunity to engage as well. Because sometimes it isn't about just always asking them. Sometimes they actually actively want to engage with some of the work that's happening. So I think having an agreed mechanism, and that's the word I'm looking for, an agreed mechanism of allowing that two-way communication is really, really important. Because if it's not there, it's very difficult then for you, I suppose, as somebody on the ground, and you probably attest to this too. If there isn't forum, you're constantly trying to create that relationship. Whereas actually, if you have a mechanism, and that would be, I suppose, my own experience from a number of different pieces, having that mechanism in place is really important.
And I think you both made a really important point about creating information that's understandable as well. I don't know if you want to say anything more about that. I know you both made the point about how you translate that data into information that's digestible and usable and understandable for different groups.
Yeah, I might take that one. I suppose, the importance of research and is to create the evidence, and we tend to generate the evidence in the way that the scientific community require it, with statistics and everything else. And that's really important, that that has to happen, and that's really important because it gives the foundation and the strength then to using the research findings to inform what you're trying to do. I do think, though, there, you know, and definitely, as I said earlier, learning for me from this particular piece was around learning to translate that into simpler language. And it's not even simple language, it's more understandable, applicable language to the audience that you then want to actually take and do something with it, to operationalize the findings from the research. So it's that constant, I suppose, being aware of the difference between the academic type of information and then what does the operational end of the system need to support them to apply the research. And I think definitely that's something that needs, you know, a little bit more effort, and something that we certainly need to do from the programme, you know, from our perspective as well going forward in terms of dissemination of the information. It will be part of our dissemination strategy to look at how we can make those messages simpler and applicable to the audiences that we're looking to engage with.
Thank you. Just another comment and a couple of questions. Fantastic to see the achievements of this programme. Any thoughts on the importance of the national policy background supporting this work? Does anything need to improve at policy level? I think this one's for you, Anita. And pivoting on the delivery model during the pandemic was obviously an important development for the programme. What elements of the adapted programme would you keep, and were there any that didn't work so well?
Oh yeah, they're really good questions. I think we have, in terms of our national policy, we have got support like from our different lead agents, a number of government departments, so Department of Education, Department of Agriculture, Food and Marine, they all have commitments in terms of certain suicide prevention training programs that they offer to the staff. So it's a good, you know, they reporting on that quarterly. I suppose sometimes uptake, you know, can vary, it can be hard to get people released from work as well for certain trainings. So I think maybe that's something we could look at as well. To try and support people maybe getting released from time to do trainings as well. I know there's good work from colleagues going on in trying to get healthcare workers, in particular in storm training in our office, like to get that and get staff released from time to do that important training. In terms of changing the delivery of the training program, I thought it's a very good program. I like really enjoyed doing it myself as well. And I went back in just to get some images again for the program. I do think like, so some of the video scenarios, which I think we will be changing for our own version, just that they're not really relevant. It's maybe, you know, vets in America that like aren't, you know, we can't relate to some of those examples of what they're going through. So we'd be looking to try and get some more kind of Irish content into it. And also, I just think the examples were good, and maybe just, yeah, the acting was good as well. So there were good actors in it who were given good depictions, and maybe more of the text-based as well chat in it, because that's, you know, a lot of what we do. Our communication has changed a lot now, so I think we could get some more examples of that into our program. I hope that helps.
Thanks. A couple more comments about the fantastic work that's going on in both programmes. So just want to thank both of our speakers once again for such excellent and informative presentations. I think we've learned an awful lot about both of the national programmes this morning, particularly about applying research into practice and also how to inform policy through the work that you're doing, and as well as the participant narratives. That's really important. So thank you very much, both of you, and hopefully we can have an update from you both next year in next year's seminars. So I also want to thank Cheetah Murray, who stepped in at a late stage to support the running of this event this morning and the work associated with it, and also my colleague Mary Morrissey for her assistance with the events. And a particular thank you to all of you for attending today. So our next and final seminar of the year will be taking place on November the 30th, when we'll have two presentations from university colleagues talking about involving the voices of patients and also members of the public and their perspective on working with the public sector. So just to remind you, and finally, that if you do have any suggestions for topics for forthcoming seminars, please let us know, and we look forward to welcoming you in the future. So thank you very much, and goodbye to everybody. Thank you.